So you have my screen now?
Yep, we can see it.
Okay, great. Thank you so much again, Dr. Paul. And thank you so much, everyone, for joining us. So tonight, I'm going to talk a little about the silent variables with the load outcome on our PRP outcome and PRP therapy outcome and results in the clinic. So, okay. So my outline is going to be, I'm going to talk about the patient baseline blood, which is very important. I'm going to start with the very simple parameters we need to consider in our practice. Unfortunately, only in the MSK Society, we mostly check the details of the baseline, but for other fields, still we need to work on it, and we need to consider different parameters, not just preparing the PRP and use the PRP, because tonight we are going to find that how important some very small and tiny factors for the outcome of our PRP. So we're going to start with the patient baseline, very simple, and then lifestyle and some factors like diet, supplements, medication. Already Dr. Paul talked about that. And after that, we are going to talk about some other factors during the preparation of the PRP and how they can influence on the outcome and function of our PRP. So my disclosure, I'm the scientific director of the site, so it probably I do have a potential conflict of interest, but our goal today is to support open scientific discussion. This content is educational and not intended as medical advice, at least my content. So I'm not a physician. You know about the PRP. We use the PRP in our practice at the different field of the regenerative medicine because it's enriched with different growth factors and cytokine. I named the main player of the PRP 10 years ago as a brainless genius, which is depleted without a nucleus, but it acts very, very intelligent, and it has different types of the growth factor can release and cytokines, and it provides us in the PRP two different functions. It could be pro-inflammatory and inflammatory biologics, and it could be anti-inflammatory biologics. So when we want to use the PRP, we need to consider these dual function and dual role, and then based on our aim and purpose, we could manage how to use the PRP and how to enhance and boost the outcome using the PRP. So the general concept of the PRP using the centrifugation technique is separating the different component of the blood, specifically isolating and recovery the platelets as a main player and other cellular components like leukocytes from the blood, but discarding and excluding the red blood cell, which is not a good guy for the regenerative medicine. And then today we have different kits in the market and different techniques to recover the cellular component of the blood. And in the general, we name them as a PRP. And so you know the PRP better than me today. So I talked about that. Before anything else, we need to define the primary purpose of the using PRP for our practice, for our goal. If is our goal regeneration, inflammation control, or both? This first system is essential because it shapes everything that follows the PRP formulation, delivery method, and even the treatment frequency. This function, the regeneration and inflammation modulation are not mutually exclusive, but their dominance depend on the several factors. Could be based on the composition of the PRP, including the leukocyte content, proteins, and activation state. And also it can target different tissues. Based on the different tissues and based on the different aim, we could control and a little manipulate the formulation of the PRP. And also the dose and delivery method is going to be very important when we decide for what indication, for what pathology, and for what aim we are going to use the PRP. So as you can see in this cartoon, PRP can provide us both anabolic and catabolic cytokines and growth factors, and we can decide which feature we are going to use, and then by some manipulation we could more redirect the PRP toward that purpose, because at some point regeneration and anti-inflammatory treatment is going to be in conflict to each other. So based on that, we decide to have which one, and then we could include some of the components more like leukocyte, or some of them less in our formulation. So you definitely heard about the inconsistency in the outcome of the PRP, even when we keep some of the parameters and factors in our PRP same. For example, even if we use the same dose of the PRP with different technique and different kit, but sometimes we have inconsistency in our practice, and why it happens. So it depends to some other parameters sometimes we don't consider them. For example, blood pressure. So we have hypertension and we could have the acute blood pressure. So how many of us, when we want to do practice or we want to do treatment with the PRP, check the blood pressure before drawing the blood, and we'll follow the blood pressure of the patient? Because definitely when we have hypertension, it can affect on the quality of the platelets, and it changes some parameters of the platelet like MPV, MPM, and MPG. Hypertension can somehow prepare the platelets to be more close to activation, and at some point maybe they can be activated in our peripheral blood, and they already release some of the useful growth factors. We need them for regeneration, and when we draw those platelets from the systemic blood through peripheral blood and prepare the PRP, we don't have that enough growth factors or cytokine we need, because we don't we didn't have the neutral and healthy platelet in our PRP in our body. So one of the important things we need to consider, if our patient is suffering from the hypertension or even acute blood pressure, we can check before drawing the blood for to make sure everything is in the normal situation and condition. So another thing is the supplements and medication, and Dr. Paul already talked about some of the factors that can, some of the medications we already check in the practice and the clinic to make sure we don't have any conflict or contradiction using those medication. But some of the supplements and some of the foods and diet also can influence and affect on the properties of and function of the platelet in the body. For example, if we use a lot some of specific supplements like omega-3, so definitely omega-3 with the dose over 600 milligram to 6,000 milligram for a long time, although it's very useful and good for overall health and cardiovascular disease, but it can affect on the platelet and reduce the potential of the platelet to be activated. What does it mean? When we want to use the platelets in the PRP, after injection of the PRP, we want the platelet to get activated and release the cytokines and chemokines, growth factors upon the degranulation. But when we are on the diet with some specific supplements like omega-3 for the long term, already they affect the platelets, and our platelet won't be that sensitive to get activated after preparing the PRP and injection, the platelets. So it's better if we want to do practice, if we want to draw the blood and prepare the PRP from the patient already they are taking the omega-3 or vitamin C with the dose over 1 gram per day, or vitamin E, which is another good supplement for the overall health. But if our patients already taking the vitamin E over 3 months with the dose over 300, it's better to stop these medication, these supplements, at least 2 weeks before drawing the blood. Because when we have the patient with these supplements or medication, definitely the quality of the platelet significantly less than the quality of the platelet when we have on the patient without these supplements. Another one is the magnesium, and magnesium also with the dose over 800 milligrams for more than 3 months can reduce 30% to 40% of the capacity of the platelet for aggregation and activation after injection through the body. We still have high number of the platelet if we go for the high dose of the platelet, but assume 40% of our platelet cannot be activated anymore, even when they are gonna exposed with the collagen. About the diet, so one of the things, again, we have different types of diet, and we are gonna follow the healthy diet like Mediterranean diet, or using herbal-based diet. But in overall, for the health, they are going to be very, very good and useful. But in the case of PRP and drawing the blood for PRP preparation, if we use a high amount of the dark chocolate, definitely it affects the PRP activation potential. So without PRP activation potential, we definitely have less amount of the growth factors and cytokines and all of the regenerative stuff we need from the PRP. Another one, it's the nitrate-rich food like radish, like beets. So most of our patients in the elderly age, they are using beet, or they are using garlic or something like that for the cardiovascular health, which is very good. But some essential molecules in these specific food or diets, they can affect the PRP function regarding to activation of the PRP and release the cytokines and growth factors. For example, in the garlic, definitely allicin of the garlic can, and other sulfur compound can inhibit the platelet activation after injection, the PRP. So I know some specific countries, they have garlic in their regime, in their diet. So it's better to keep in our mind when we want to use, when we want to draw the blood for the PRP preparation, at least ask our patient to stop 2 weeks in advance. Why 2 weeks? Because mostly in average, our body can replace the platelets every 8 to 10 days. And the optimum life of the platelets in our body is something around 10 days. So we say 14 days just in case, to make sure when we stop the medications, when we stop the supplements or any diet. So after 2 weeks, we have mostly our new platelet without any influence of these specific diets or supplements. Another one is the alcohol, and caffeine. If we are using lots of the caffeine or alcohol or sugar, definitely they can affect on the 50% of our platelets. So we need to consider: do we need just quantity of the platelet, or we need to consider quality of the platelet? Something very, very simple and very small that they can make the big difference at the end of the treatment as the outcome of the PRP therapy. So exercise. So one of the trick we could use to increase the platelet number is the exercise. There are some studies, they showed if we have moderate exercise for a long term, it can be helpful to increase at least 7% to 18% of the number of the platelets. But recently, one study showed even if we have very intense exercise, to reach 100% of our cardiac capacity, VO2, for 4 minutes. For 5 minutes, we could increase the number of the platelets by 35%, which is very good. And also we could increase the growth factors, one of the essential growth factors, TGF-beta, just with short, intense exercise. In the case of when we have patients with a low baseline of the platelet, we could do some trick like this to increase the number of the platelets at the baseline of our patient. Another thing I'm going to talk a little about during the preparation of the platelet. One of the things we need to consider is using the anticoagulant. What types of anticoagulant we are going to use? Most of the market available kits, they provide the different anticoagulants, and so each of them have advantages or disadvantages. So regarding to the anticoagulant, the famous one is those 4 anticoagulant we know as heparin, EDTA, ACTA, and sodium citrate. So today we have a kind of consensus about the avoiding using the EDTA and heparin. So EDTA can change something irreversibility about the calcium signaling and calcium flux through the platelets. It's very, very strong calcium chelator, but when we use the EDTA, sometimes after preparing the PRP, even when we recalcify the PRP and exposing to the collagen, we don't have that level of the activation which is desirable for us. So that's why we cannot trust on the EDTA. Same regarding to the inconsistency, we saw that when using the heparin, we don't recommend using the heparin. And today in the market, most of the kits are going to use citrate or ACDA. But one of the question, which one we should use? Mostly based on the literature, ACDA, when we use the ACDA, since it's more acidic, the recovery rate of the platelet is going to be more than citrate. But there are some consideration and concerns around the citrate. Based on the reports in the literature, when we use the ACDA as anticoagulant for our PRP preparation, at least 3 times by 6 times, we have greater level of the glucose at the baseline of our blood. So what what happens when we have that level of the glucose, high level of the glucose. When we inject the PRP, we are going to create a kind of local diabetes for our injury site. So definitely that high level of the sugar, high level of the glucose can affect the angiogenesis properties of the PRP. If you remember our conversation from last webinar in the Toby, I talked about the angiogenesis, which is one of the most important function of the PRP. When we use the PRP for regenerative therapy, for regenerative medicine, we need to have the angiogenesis. In the 99% of the cases of regeneration, we need angiogenesis. Only in the 1%, maybe we don't need that angiogenesis. So, and PRP has started its duty with this function. So if we kill this function, so what? What we can get from the PRP if we don't have the angiogenesis? There are lots of studies, molecular mechanism, and in vitro, in vivo study. They showed that at the high level of the glucose, we definitely hinder the function of the VEGF, which is the most important growth factor regarding to angiogenesis, and then we increase the apoptosis. So if we want to use the PRP for regenerative medicine, we need to consider this tiny things regarding to the preparation of the PRP, but we can find that tiny things can change it very, very big and significantly difference of the outcome. So we have a couple of the studies and the reports in the literature that they found that when we have high level of the glucose, it doesn't affect just on the platelet, it also affects on other cells. For angiogenesis, we definitely need to recruit the endothelial cells, and one of the function of the platelet is recruiting the other cells, stem cells and endothelial cells. So for angiogenesis, the most important function of the endothelial cells is tube formation. With high level of the glucose, we stop the tube formation, we stop the cell migration, and we don't have any angiogenesis sprouting, and we don't have angiogenesis consequently, we don't have vasculogenesis. So we need to consider that. There is a study regarding to the in vivo using the ACDA and comparing the ACDA with the sodium citrate, and sodium citrate when we have just bare sodium citrate and when we add the glucose to sodium citrate. You can definitely find that in these cartoons when we use the sodium citrate alone for our PRP preparation after 6 days, we almost have a kind of more than 60% wound closure. But in the case of ACDA and other treatment or other preparation using the glucose, we won't have any effective wound closure. And even if you look at the histology pictures, you could see how organized collagen structure on the case of the PRP prepared using sodium citrate versus the groups we use the PRP prepared by the ACDA, and we have significantly high level of the immune cells infiltration in the case of PRP treatment with the ACDA prepared PRP compared to the sodium citrate prepared PRP. So we also check that in our laboratory here with one of our competitors with the same recovery rate in the market. We are using sodium citrate and they're using ACDA. And if you look at this result, you could find after preparation of the PRP, we could keep the level of the glucose as a baseline because when we draw the blood, we use that blood to test the pH, and then after preparation of PRP, again, we use the PRP to check different parameters, and you can see M-side system can keep the glucose level as a normal, but another kit with the ACDA can increase the glucose level at least 5 times, 6 times more. So still, we have same number of the platelets, same deliverable dose, but different glucose level. So definitely we have different outcome, even with one tiny variables. About the activation or not activation, there is lots of disagreements. But we need to consider that again, what purpose and what aim we are gonna follow using the PRP. If we want to have immediate release of the cytokines, maybe we need to activate prior injection or even using calcium as a kind of pre-activation. It depends to the concentration of the calcium we are using. If we use the calcium less than 4%, it's going to be mostly recalcification. In most of the case, we don't need that because 4% provide us 10 millimolar calcium, but we need only 2 millimolar calcium as a physiological calcium level. And upon that injection, the PRP platelet can receive that, uptake that from the tissue. But if we want to accelerate the activation, we could add 4% calcium. Again, if we don't add the calcium, it won't be any problem. And we mostly suggest for musculoskeletal regeneration, clinical application, and knee osteoarthritis, we don't need to add calcium. And upon the injection, PRP can receive that calcium within the tissue. And for some other applications like skin treatment and microneedling, when we need to immediate and burst a release of the cytokines, maybe we could use the activation in advance. Or in some case like wound healing, wound dressing, when we need to have the scaffolding, yes, we can use the high level of the calcium, maybe 10% of the calcium. In this case, calcium gluconate is better than calcium chlorate, which provides us more release of the growth factors. And also we could use some other activators like thrombin instead of the collagen to make the scaffold. And one thing we need to consider when we activate our PRP, when we prepare our PRP, we need to consider our growth factors half-life is very short. Based on the literature, in most of the cases, in 90% of the cases, when you read the literature, they say, okay, upon the activation, gradually we have more and more and more and more growth factors, and the trend is increasing. But the thing we need to consider that with the current available techniques to measure the growth factors, yes, which is true, the trend is increasing, but who guarantees if we have the bioactive growth factors? If you look at this chart for VEGF, we have half-life something around 20 minutes, 30 minutes. For TGF beta, we have half-life something around 3 minutes. So we need to consider if we activate PRP for injection, we need to inject it immediately if we want to get the benefit from the TGF beta or other growth factors. But some case we don't need to get the benefit from TGF beta, and even the presence of the TGF beta is going to be a kind of it's going to be detrimental for us. So on that case, maybe we could do some trick, activate in advance, and then inject our PRP 10 minutes later. So with consideration of these tiny variables and factors, we could manage and manipulate our formulation toward the best outcome of the PRP. And the last things I'm going to share with you regarding to the preparation technique and preparation setup. We recently worked on the technique, on the preparation technique design, and we ended up with a new not new design, new upgrade of our current design, which is going to be released in the market in a couple of weeks. So now we can offer PRP kit with over 90% recovery as monocyte-rich PRP, but still neutrophil for PRP. And for the totally leukocyte for PRP, we are going to have over 87% recovery. So why I brought that? Because one of the variables we can consider is how we are going to set up and how we are going to design our technique for preparing the PRP, and it definitely influences on the outcome of the PRP. So still, there is a question, is all PRP the same? Definitely no. We have different variables in our PRP. And one thing we need to consider that the term of standardizing the PRP is a wrong term. We need to consider that since there are lots of different variables, and it's a kind of personalized biologic with the source of the human. So we need to consider that as a personalized PRP eventually, rather than a standardized PRP and formulation. And thank you for your attention. This session is the first session of our webinar in the M-Site as a Regenerative Edge, and we are going to have monthly webinar, and the next one is going to be what, when, and where, choosing between the PRP, fat, bone marrow, and A2M, combination of them based on the different criteria and consideration factor. And the time is next month, June. You can see the time in the screen. And we are going to talk about different important factors we need to consider to enhance our practice. So thank you for your consideration. Now I think we can go for the question and answer session if you agree, Dr. Paul.